Hello, my name is Anna Malinow. I am past president of Physicians for a National Health Program and a general pediatrician in San Francisco. We will be spending the next 15 minutes or so talking about direct contracting entities, the latest attempt to hand Medicare to Wall Street. Now, the takeaway for today's talk is summed up by a quote I first heard at a PNHP conference many years ago. When Willie Sutton, a famous bank robber in the first half of the 20th century, was asked why he robbed banks, he supposedly responded, because that's where the money is. Now keep that money in mind as we go through the next 15 slides. By the end of the session, you will be able to describe a brief history of Medicare, Medicare Advantage, and the Medicare money machine, understand the Innovation Center and the global and professional direct contracting model, and finally discuss a winnable strategy to stop direct contracting entities. Now, Medicare has become a tale of many acronyms that some that you've heard of and some you wouldn't expect to see in medicine. Of course, there is TM, which stands for Traditional Medicare, CMMI, the Center for Medicare and Medicaid Innovation, also known as the Innovation Center, GPDC, Global and Professional Direct Contracting Model, DCEs, those are the direct contracting entities, PCPs that I thought were primary care physicians, but no, they're investor-owned primary care practices, MSOs that aggregate those practices. MA stands for Medicare Advantage Insurers. SPACs are special purpose acquisition companies. PE are private equity firms. VC are venture capital firms. And IPOs are initial public offerings. Now, the United States is the only high-income country that does not provide healthcare to all its residents as a human right. In 1965, Congress passed, and as we know, President Johnson signed Medicare into law to cover the healthcare costs of seniors 65 and older. As we know, there is Part A that covers 100% of hospital charges and Part B that covers 80% of outpatient charges, requiring seniors to go into the private insurance market to purchase Medigap or supplemental insurance to cover the 20% of uncovered services. Now, in the 80s, commercial insurance was introduced as Medicare Plus Choice to give seniors a choice of health insurance plans and to achieve the so-called efficiencies of managed care in the private sector. In 2003, Congress passed and President Bush signed the Medicare Prescription Drug Improvement and Modernization Act, implemented in 2006, which added prescription drug benefits to Medicare and renamed and redesigned Medicare Plus Choice into Medicare Advantage. And in 2010, Congress passed and President Obama signed, as we know, the Accountable Care Act that, among other things, established the Center for Medicare and Medicaid Innovation, also known as CMMI, gave them a $10 billion budget every 10 years to test innovative payment and service delivery models to reduce program expenditures while preserving or enhancing quality of care. Importantly, it authorized them to issue regulations free, and I repeat, free of congressional action, and scale up any model that fulfilled their criteria to the entire, and I repeat, entire Medicare program. And that's where we find ourselves today. Now, many health economists hold to the idea that excessive healthcare costs in the United States are due to two things: physician greed and patients getting too much care. In other words, the fee-for-service model that pays for volume. Their solution is to squeeze physicians and then to squeeze patients. Now, to squeeze physicians, they recommend shifting insurance risk to doctors and hospitals, holding doctors accountable for the cost of care, giving them capitated payments for certain population of patients by creating such things as HMOs and ACOs and PCPs and MCOs and IDSs and now DCEs or direct contracting entities. Then you squeeze the patients and make them stop getting so much health care. You increase deductibles, copays, coinsurance. You underinsure them, make them choose between a whole pill and a half, 3 meals a day or 2. This is how the US uses market forces to control prices. Now, as you can tell from this graph, which compares the increase in Medicare beneficiaries shown by the green bars and Medicare spending shown by the red bars from 1970 to 2020, market forces have not worked all that well to control Medicare costs, although you can argue that since the ACA, healthcare costs have risen at a slower pace and the cost of Medicare compared to commercial health insurance have always risen at a slower pace, but still, the Medicare budget in 2020 was $926 billion. Now, privatized Medicare, otherwise known as Medicare Advantage, shown in the red bars, has grown as well, from 7 million beneficiaries in 2000, not growing very much until the implementation of the Modernization Act in 2006, then more than doubling after the passage of the ACA in 2010. What is the Medicare Advantage? Why so popular? Well, the Medicare Advantage business model is quite simple, although it does require hiring a bevy of very smart actuaries. First, you make sure that you insure the right population, otherwise known as cherry picking. 2, make sure you don't insure the wrong population, otherwise known as lemon dropping. 3, you offer inexpensive premiums and health benefits. You upcode and make a profit, and then you give back some to improve the product, such as lower premiums, out-of-pocket caps, cheap eyeglasses. You market to the right population and repeat. Now, at the risk of telling you something that you already know, let's quickly go over just how this risk score gaming works, a scheme that would make Willie Sutton blush, and which is how Medicare Advantage has been drawing serious overpayments since its full implementation in 2006. Medicare Advantage does this by submitting diagnosis codes that create more of what is known as the CMS hierarchical condition categories for each patient. So let's see how this works. Let's look at a 76-year-old female with obesity, type 2 diabetes, major depression, congestive heart failure, with a risk score of 1.03. Now, CMS would pay a Medicare Advantage plan that does not upcode $9,000 for that patient. If, however, the Medicare Advantage plan upcodes, meaning same patient, same medical conditions, but more codes, and gets her risk score to 3.63, CMS will pay that Medicare Advantage plan $32,000. The plan reaps obscene profits, some of which goes to marketing, some of which goes to improved benefits, driving up the number of new members, but most of which is going back into profits, all the while draining the Medicare Trust Fund, driving up Part B premiums, and diverting money from other social services and goods. Now, for each 0.1 increase in risk score at current enrollment levels, there are $15 billion in overpayments, $13 billion from CMS, $2 billion from Part B beneficiaries, and the Medicare Advantage plan takes $3.5 billion in profits. That's for every 0.1 increase in risk score. Risk score gaming creates a major transfer of wealth from taxpayers and traditional Medicare recipients to Medicare Advantage plans. And this is a Medicare Advantage. But wait, there's another piece of the pie waiting to be raided. Medicare Advantage plans account for only 42% of Medicare beneficiaries, and traditional Medicare accounts for 58%. Now, taking home a portion of the $389 billion is fine. But what if these corporations could take home a portion of the entire $900 billion pie? Now, that's where the money is. I'm going to be borrowing heavily from a recent health affairs blog published 3 weeks ago by Rick Gilfillan and Donald Berwick, where they described the Medicare gold rush created by Wall Street speculators as they increased the valuation of a Medicare Advantage beneficiary's covered life from an average of about $7,000 to $87,000. Now, to put this into context, Medicare typically pays $12,000 per year per individual. What happened? Did seniors suddenly get really sick? No, the system just got really sick. 4 main business realities drive the interest in these Medicare-related acquisitions. 1, expected doubling of Medicare spending from $800 billion to $1.6 trillion in 2028. The consistent overpayment by CMS to Medicare Advantage plans, despite any lack of clinical benefit. The distorted market dynamics that result from these CMS overpayments. And finally, the direct contracting model hoping to privatize part of that $1.6 trillion spend. Which brings us back to the CMMI, the Center for Medicare and Medicaid Innovation, which, if you remember, was tasked with developing models to lower costs without worsening outcomes, without congressional oversight, and then scale models to the entire Medicare population. Now, in 2017, the Trump administration decided it wanted to de-risk all of CMS and pass the entire fee-for-service beneficiaries to a Medicare Advantage-like full risk capitated arrangement. In 2019, it unveiled the GEO model, which involuntarily aligned all traditional Medicare beneficiaries to a DCE in 10 large cities without the ability to opt out. Now, in 2021, the Biden administration did halt the GEO model, but it greenlighted the global and professional direct contracting model, which allowed CMS to contract with 53 direct contracting entities in 38 states and DC. Now, the DCEs are a Medicare Advantage-like intermediaries with defined provider networks, although beneficiaries do maintain access to all Medicare providers. There are some very complex constraints on risk scoring, which might or might not be enforced, and it looks like their medical loss ratio will be about 60%, allowing for plenty of home-taking profit. Beneficiaries are aligned through claims, where they access the most healthcare, or voluntarily through their PCPs, their primary care providers. They will get a letter in the mail from the DCE, which they might or might not read, might or might not understand, and presto, you now have a potential 30 million out of the 38 million beneficiaries out of fee-for-service and into a capitated risk-sharing program. Oh yes, these are beneficiaries which specifically chose traditional Medicare because they did not want to align themselves with a Medicare Advantage plan. Well, too bad. Of the 3 GloPro or global and professional DCEs, most are investor-owned. 25 are provider-based and controlled, a mix of ACOs, some for-profit PCPs, and specialty groups. Now, 28 are investor-owned. 22 are either publicly traded or publicly backed by private equity and venture capital firms. Now, the 6 insurers that are the Medicare Advantage insurers that are in the DCE market operate in 19 states with 57% of the entire national fee-for-service population and can eventually cover up to, or potentially cover up to 20 of the 30 million lives up for grabs. So when we say DCEs hand traditional Medicare to Wall Street, we are not kidding. Remember the 80s, giving seniors a choice of health insurance plans, achieving the efficiencies of managed care in the private sector? Didn't go so well unless you own stock in one of these 5 commercial insurance companies, which in the last 11 years had an average stock price increase of 800% and whose average market capitalization increased almost 500%. Compare this to the entire S&P 500, where stock increased 280% and market capitalization increased 245%. All of this tells us what Wall Street already knows. Medicare Advantage and now DCEs is the place to be. And where is our place? As physicians used by insurance companies to upcode and now deliver patients to them, as willing collaborators of the new DCE Medicare money machine? I don't think so. So the first thing you and everyone should do is go to PNHP.org and sign the petition to stop DCEs. This is a petition that will be sent to Health and Human Services Secretary Becerra demanding a stop to DCEs. We have over 3,000 signatures and are hoping for 1,000 more before we send him the petition. And then you can call or write your member of Congress demanding an end to the DCE program and for them to protect Medicare. You can write a letter to the editor. Physicians, please collect letters that your patients are receiving from the DCEs and send them to me. That's my email. And seniors, if you receive a letter from DCE, send me a copy. We hope to organize a truth campaign around these letters. Educate yourself about this complicated issue. It's made complicated for a reason. We are expected to throw our hands up in the air and walk away in confusion. Don't do that. Instead, watch the DCE webinar and walk away angry and ready to fight. And always collaborate with organizations and organize for national single payer Medicare for all, because as Willie Sutton said, It couldn't be more obvious. Thank you.